Splinting and fracture care are the S in the march-pause sequence and take place in tactical field care once all other life-threatening injuries have been addressed. The basic splinting techniques for tactical combat casualty care, or TC3, are splinting using a malleable splint and splinting using rigid splints. The difference between malleable and rigid splint application is minimal. In malleable splints, there is an opportunity to form the splint so that it follows the natural contours of the extremity and more readily secures the fracture in its normal anatomic alignment, which often reduces the pain for the casualty and decreases the likelihood of further injury, which are two of the primary objectives of splinting. Rigid splints require more padding to maintain that alignment and can be less effective if not properly applied. When applying a splint, consider body substance isolation and have a combat lifesaver or CLS or other responder help you whenever possible. Identify the location of the fracture and place and support, or have a CLS place and support, the extremity in a neutral position or position of function. Assess the pulses, motor and sensory function distal to the fracture. If pulses are absent, you may gently reposition the extremity to see if realignment restores the pulses, taking care not to further injure the casualty. Remove any watches or jewelry, as significant swelling can occur later. Treat any open injuries, ensuring bleeding has been controlled and that the wound is properly dressed prior to splinting. Gather all of the materials you might need. Many of these are found in the individual first aid kits, like gauze, a cravat, an elastic bandage, and tape. Others may be found in combat lifesaver kits or in a combat medic bag. This might include a malleable splint, additional cravats, tape, dressings, and elastic bandages. And if malleable splints are not available or not adequate, items that could serve as rigid splints should be collected. For example, sturdy poles or sticks, pieces of wood, or folded cardboard. Padding materials can be made from extra cloth or even some types of packing materials. Using the uninjured extremity as a guide, mold a malleable splint to form to the contour of the extremity, making it long enough to secure the joint above and the joint below the fracture. Occasionally, this will require two malleable splints secured together with wraps or tape. Malleable splints gain their rigidity by introducing curves and folds, particularly along the long axis of the splint. The shape of the splint will vary based on the location of the fracture and the joints that are being immobilized. If a malleable splint isn't available, then measure and shape rigid materials against the uninjured extremity to make sure they are long enough, but not so long that they will interfere with casualty transport once applied. Avoiding gross movements, apply the splint along the fracture bone, keeping it in a normal resting position. If there are voids created between the splint and the extremity, use padding materials to fill them and minimize the pressure on the injured area. This is particularly true for rigid splints, which often require significant padding to avoid putting pressure on the fracture. Make sure to leave access to check a distal pulse if the splint might involve the area near the distal pulse. Then, using elastic bandages or cloth strips, like cravats, tie the splint to the casualty both proximal and distal to the injured area, avoiding pressure directly over the injury. Make sure that both the joint below and the joint above remain immobilized. Also, ensure that the knots are tied over the splint and not on the extremity. If there are any loose cloth strips from the knots, tuck them in to avoid having them get caught during casualty movement. Depending on the fracture location, you may want or need to secure the splinted extremity to avoid movement during transport. For upper extremity injuries, this is often done using slings and/or swaths, which pin the arm to the torso. For lower extremities, it may involve tying the legs together if the situation allows. Litter straps can also perform this function, but make sure that they are not applied directly over the site of the fracture. Once the splint is applied, reassess the distal pulses, motor and sensory function, and compare it to the baseline you established prior to putting on the splint. If the splint is too tight and compromises the extremity, loosen the ties or bandages, reposition the splint, and then re-secure it. Administer pain medications as needed and antibiotics for any open fracture. And as always, document all findings and treatments on a DD Form 1380 TC3 casualty card and attach it to the casualty.